Good day, everyone. My name is David Shire. I'm one of the clinical assistant professor here. I will be moderating our next session. It's with a great honor and pleasure to introduce our next speaker, Dr. Mike Pulsipher. Dr. Pulsipher is currently the Division Chief of Pediatric Hematology Oncology at Primary Children's Hospital. He's also the Director of the Children's and Adolescent Cancer Initiative at Huntsman Cancer Center and the Presidential Chair in the Pediatric Oncology Hematology at the University of Utah. He also served just in the recent past as the Group Chair of Pediatric Transplantation and Cellular Therapy Consortium, recognized for his contribution and leadership in the pediatric stem cell transplant field. He received a PTCTC Lifetime Achievement Award in 2020. He's the author of more than 260 articles in peer-reviewed journals and 17 book chapters. His seminal work include testing haploidentical approaches and assessing the role of NGS-MRD in improving transplant outcomes. Dr. Pulsipher's work in cell therapy helped lead to the FDA approval of the first CAR-T treatment, now well known as Kymriah. He's going to talk to us about the optimal dosing of ATG in alpha-beta haplo transplant. Thank you so much, Dr. Pulsipher.
So following on this really great science, we're taking a completely clinical pivot. So hopefully people will enjoy. What I want to do today is really kind of following along some of the nice themes that Rupert started, talk about optimization of our treatment protocols. Because I think that all of us are recognizing more and more that we know the problems that we make for ourselves. We understand that we can give certain preps that are too intense. We can put ATG in the wrong place. So bottom line, one of the chief things that we're doing nowadays to really help with our outcomes is to optimize them and make them better. And I want to really focus on this. So as far as disclosures, I have received a little bit of help from Miltenyi through the years, but no other relevant things to this particular talk. So this story, again, it's really started with a challenge that I gave to Wing Leung, and this was many, many years ago. Wing presented some really nice outcomes with alpha-beta haplo, and at the time he was starting to get into CD45 RA depletion, and he really showed that at single center, St. Jude, it looked like haplo had better outcomes than other transplant approaches. So essentially, you know, I'm always skeptical of single center data because patients can be skewed, and there's the way to really show things that can hopefully help us improve the field is to get in the hands of multiple centers and try to do a protocol that you can actually do across multiple centers. So I challenged Wing about that, and he said, okay, fine, if you don't believe this, then let's put together an R01 and do a multi-center study, which we did. And the question was pretty straightforward. What we wanted to do was prove that using haplo in a multi-center trial, we could improve outcomes. And we chose to do cure favorable, but no one knows how to define cure favorable, and no one knows if cure favorable actually really matters or not. And although Alicia asked me to speak about that, I really can't address that particular issue very well, since the field is so confused. But suffice it to say, we did choose cure favorability, but then in the same paper showed that 80% of our patients in general that were screened were cure favorable in some fashion. So I certainly don't want to say that cure favorability matters. But what we did then is we had a variety of preps, and some were myeloablative and some were reduced toxicity. And we did that very intentionally because all of us know that we simply sometimes can't get in fully myeloablative preps and we need to use less intensity. So we had a menu to choose from, and that menu helped us make some conclusions. Now the first thing that we concluded from this, again, multi-center trial, this trial was done at 12 different centers, was a very surprising conclusion, and that's that our myeloablative approaches, our very intense myeloablative approaches, had worse outcomes than our reduced toxicity approaches. Now Rupert actually, and Peter showed this many years ago, in their case as well with the OKT3 data, that too intense of a regimen isn't necessarily good for you. But one nice observation that we made with the regimen intensity question was that TBI didn't seem to make a difference when we had MRD negative patients. And I'm not going to talk too much about that, but just keep that in mind as we get to what I really want to focus in on. The next thing we showed, of course, is that MRD made all the difference. And patients who went into a haploidentical transplant with high MRD did very poorly. So all of that was kind of understandable and explainable from previous data. But here's one thing that really bothered us. Now, if you look at this particular graph, and I'm trying to see if I can point. Here we go. So here's the overall outcome of the trial, and you can see that our haploidentical patients just, did better than all the other stem cell sources. Although statistically, the only one that it really truly did better was mismatched unrelated donors, and that's mainly because of a numbers issue. But this over here was where the question really came up. There was a profound difference in outcome based on age. Now, if you're a transplanter and you're jaded, and all transplanters who have been in the field for at least 5 to 10 years are jaded, you basically look at this and you say, well, all teenagers and older patients do worse. We know that. That's just the way life is. But Chris wanted to go a little deeper with this. And so here's a nice picture of Chris. And I think Chris really deserves all the credit for this particular thing. Because Chris looked at that data and he said, no. It's not just that they're young. It's that their ATG exposure is wrong. And one thing that many of you in this audience are familiar with is that Jaap Bolens and Rick Admiral have been working very hard on thymoglobulin ATG pharmacokinetics for the past decade or more, and they've come up with some really nice things. And when we developed this protocol, I consciously talked with Jaap, and we really strategically had some angst about where to put the ATG and how much ATG to give. And we didn't have the tools yet to really give everyone the right dose at the right time. And so we went back and forth and said, okay, we can do the -9, which is what Jaap was getting starting on day -9. We could do it there, and that's where his unrelated donor trial was going to be started. Or he said you could do it at day -12, which seems to be what I think is going to be the best time to start for cords. And that's what we decided. So here we made a kind of a educated guess. We didn't have, again, the ability to really target it well, but we targeted it at day -12 because we thought that was going to be the best for haplo. So that's what, again, led to this. Now, many of you have, again, seen this, and I want to explain this carefully so that everyone understands this concept very well, because I'm going to just present it in a way that may be a little bit confusing. So here's the key. One is your maximum concentration, but what matters, according to this model, is not just your maximum concentration, but your area under the curve. In other words, the extent and exposure, the overall exposure of the patient to ATG. And if you can see this blue section right here is pre-transplant. And we've already discussed this a little bit, but the pre-transplant exposure is very important, and it turned out to be important in our data. And you can imagine why it would be important. Your goal is to decrease T cells to a point where you're not going to undergo rejection. That's a theme we've already seen this morning. And so we knew we wanted to have a high pre-transplant exposure, something that would be optimal. And the issue here is post-transplant. We also didn't want too high of an exposure. Now, one of the things, Rupert mentioned this in his talk, the notion of cutting off the ATG right at day 0. That's a good notion, and it may be the right way to go, but we also may need a small amount. We don't know that because those T cells can expand very rapidly, as Rupert himself said. So it may be that we actually want to have a targeted lower bound as well. But bottom line, keep this in mind. We have been able to, because of Jaap and Rick Admiral's work, devise a way that we can kind of calculate that pre and the post exposure. And those associations with that are we need to know the age, height, ALC, height and weight, ALC on the day of admission, start time, actual dose of ATG, and dose of transplant, and timing of transplant. And if we do that retrospectively, we can calculate in detail what the exposure would have been. So understand that in everything I'll present, what I'm presenting is a calculated exposure, not a measured exposure. Okay? The measured exposure is part of the next study, but this was a calculated exposure. All right. So here were our methods. We took 51 patients from the original study, our main arm. These were only CR1 and CR2 patients. We then added a whole bunch more. Now, as we started doing alpha beta with this large group of centers, everyone loved it, and so we didn't want to only do it on CR1 and CR2 patients. We wanted to add CR3 patients. We wanted to add second transplant, so we did all that. And then Chris wrote his own study where he made some nice changes based on some really excellent studies that he has done. And Chris is going to talk to you about a lot of things that we learned as a group through his studies that have been done. So bottom line, we added all these patients together. We had 163 patients. Median age was 13. Median donor age, we had all sorts of ages. As you can see, we varied from age 5 to 61 in the donors, but our median age was 33. And here are our median cell doses and alpha-beta ranges. Now, a couple things to keep in mind, and that is that when we did this, most of the standard of care, of course, at the time was for patients to use an unrelated donor if they had a match, and of course a sibling donor if they had a match. So in this particular approach, one thing that I think we were very proud of was the fact that we could find donors for everybody. And as you can see here, with both our ALL and our AML population, the vast majority of our patients were either Hispanic, Black, or Asian. And so this is a nice approach, of course, that we can do to a very diverse population. One of the things also to keep in mind is this is America, sorry people, we had a very high number of patients who were quite obese. And we approached those patients by generally using reduced toxicity approaches. Rather than just CR1 and CR2, with this larger population, again, we have a lot of CR3 plus patients that came into this as well. Now, this is an important thing to understand as well. We mixed together NGS and flow. Now, of course, we don't have good NGS testing that was done at all the centers for MDS. Most of the NGS testing essentially was done on the ALL patients. But everyone in this particular review that I'll do, MRD was either NGS or flow. So we've got an awful lot of NGS mixed in there. And for all the AML, essentially, it was flow as well. We then have a mixture of approaches. And what you can see is that we have a decent percentage of TBI, but that was almost exclusively in ALL patients. And another important thing to understand is there were a lot of ALL patients that did not get TBI in this as well. And of course, very little TBI in other patients, and almost never in our AML patients. And this is another important distinction to make. Now, most of our centers started on day minus 12, as I mentioned, and kept doing it on day minus 12, even when the initial study closed. But we had some centers who did it earlier, on average starting at about day -9 or day -8. So we had a good blend of start times as well as a good blend of preps. Now, one thing also that occurred, and I think that this is interesting, is over time, there's been a big push in the Haplo field, and all of you have known it and felt it, that the notion is the younger the donor, the better. And this is something we really need to prove, but I think there's really good evidence to suggest that it's probably a good thing. So we had an awful lot of siblings who were our haplo donors as well. And we had the appropriate mix of CMV. Now, let me take you through this particular figure, because it looks confusing, but I want to drill it into your brain, because this is the way that I want you to think about these optimal exposures that we're trying to establish. So essentially, we took that early peak. You remember that was blue before that, the pre-transplant exposure, and we put it on this axis, okay? And so what you see here is 50. This is the area under the curve that when we did some really careful statistical analysis of this, 50 was what we came up with. And so we decided to draw a line at 50 right here. Now, this axis is the post-transplant exposure, all right? And so you see here 12. And this is the cutoff that we came up with. Now, this is very close to what Japan has come up with unrelated donors, where he has been targeting about 40 for the peak and less than 10 for his trough. So we came up with something that was very, very similar to that. And so any given individual is someone, this one patient had a peak of 50 and a trough of 12, so right there at the corner. So this divides into quadrants then, and so you're going to hear me say quadrants a lot. Now, quadrant number 1, we determined to be our ideal quadrant with a very high peak and a low trough, okay? And what are these colors? Red, of course, is non-relapse mortality, and blue is relapse. And what you see here is there's a lot of red over here in quadrant 4, and there's a fair amount of blue that is down here. But notice there's not a lot of red and blue in this area, and so you can see a disease-free survival of 86% here. And in the others, disease-free survival varying from 48 to 64%, with very few people down in quadrant 3. They just didn't land there. So that's where we start, and now let's dissect this just a little bit more. We're going to call this line, which was quadrant number 1, our optimal exposure, where we had a very high peak and a low trough. And you can see here a really outstanding disease-free survival that approaches 90%. The other 3 quadrants kind of blending together, so essentially for the purposes of the rest of the analysis, we combined those 3 quadrants. And what you see then here is some interesting analyses about each of those major outcomes. And the first one is a little bit confusing, and I hope to explain it later. And what this is if you look at outcomes, you see we have the full or half siblings. An awful lot of our patients were treated with these very young donors, and it looks like here that we have a pretty high percentage of non-relapse mortality. And at first glance, one could look at this and say, wow. We want the moms and the dads to be our donors because we have too much non-relapse mortality. But you'll see a little bit later that the ones who had non-relapse mortality were ones who had siblings who were also teenagers. These ones who donated were teenagers, and their recipients were also teenagers who got really bad ATG exposures. So that's going to go out in multivariate analysis. So don't get confused by that. But it begs the question, when we try to address what the best donor is, there are other factors that can totally mess us up when we do our analysis. Now here's another thing that is very important and remained important. What you can see here is we would expect this, of course. A CMV recipient negative, donor negative is going to have a great outcome in low non-relapse mortality, right? And beautifully only 4.2% when you had CMV negative. And you throw in CMV and all of a sudden it affects your mortality. And look at this, recipient positive, donor negative, and all of a sudden you have 38% non-relapse mortality. And this stayed in multivariate analysis. So, looking at this analysis, I am very hesitant about, if a recipient is CMV positive, about giving them a CMV negative donor. Okay, so let's talk about relapse. And we saw here some associations that you would expect. And that is, of course, if your MRD status was positive, then you're going to have a very high level of relapse. But if it was negative, you're going to have a low level of relapse. Here as well, and this is an important thing, what we mean by targeted agent after transplant is a patient who was on a TKI after transplant, or a patient who had AML and was on something like sorafenib post-transplant. So a targeted agent at their specific molecular lesion. And the amazing thing about this one was that no one who had a targeted agent on this study. Now, there were only 19 of them, so it's not a very high number, but there was no relapse in those targeted agents, suggesting that, that targeted agent helped a patient get to the point where immune recovery was better. And then, of course, this small, at least timing of ATG, if it was started less than day -10, then the relapse rate was very high compared to if it was started a little further from the transplant. Now, let's talk about disease-free survival. MRD status mattered, CMV status mattered, and this proximal versus distal status all mattered in that particular analysis. Now, how about the original hypothesis that we had that age mattered? Now, what we see here is those who are older than 10 years are really clustered to be in this, what we call, remember the quadrants, 1, 2, 3, 4. There's a lot of older patients that end up in quadrant 4. So age really is very different, whereas the young patients who go through ATG much more quickly tended to be clustered in number 2, and a whole bunch of all ages who were dosed well ended up in the good quadrant. How about BMI? Does that matter? And one interesting thing is, based on this model, we couldn't really predict where the high BMI were gonna land, because they were all over the map based on how they were dosed, here, there, and everywhere. And probably some of this was just to the fact that the ATG was dosed differently. We don't know how to dose ATG for very, very heavy patients, and so people were dosing it all over the place. And so I can't really address BMI very well in this particular talk. But we definitely can say for sure, if you start your ATG very early, you're going to cluster over in number 2. Okay. Now, one other thing that's really important, and this is something that matters a lot in outcomes here, and that is part of the formula for calculating PK relies on ALC. And if you have ALC that is very low, you're going to push your doses very high. So that's another important thing to keep in mind. All right. So let's look at acute GVHD by ATG exposure. And when you look at this 1, 2, 3, 4, that's each of the different quadrants. And the interesting thing that we noted, those of you who do a lot of alpha beta know that you get a lot of early skin stuff and high fevers, and then it tends to get treated and it goes away. So a lot of that's recorded, of course, as GVHD. We really didn't see big differences in GVHD at all. It's just there, and it didn't seem to matter. But chronic GVHD mattered a lot, and this makes very good sense. So quadrant number 1, that was our ideal quadrant. We had, about 10% chronic graft versus host disease, and any transplanter wants 10% or less. But quadrant number 2 and quadrant number 3, where you didn't get a high pre-peak, had much higher rates of chronic graft versus host disease, 30, 45%. And so, one could make, when I'm done with this, you could make the argument, just forget the ATG. You shouldn't have given any ATG. But no, it seems like ATG matters. I think it's important in getting the graft in, but it also matters very much because if you get the right exposure, you are decreasing inflammation enough and decreasing T cells enough that your chronic GVHD is less. I don't know how that works mechanistically, but it's a very intriguing observation. Okay, so again, let's do some multivariate analysis, and what you see is that the overall difference between the donors tended to disappear, but the CMV serostatus mattered for non-relapse mortality, and the quadrants matter for actually, individual things, but it wasn't overall statistically significant. For relapse, the key things were MRD and where you are. And here's an interesting thing. Yes, MRD positive mattered a lot with a very high hazard ratio, but these hazard ratio for being in the wrong ATG exposures were a little higher, which was very intriguing when we first looked at it. Disease-free survival, same thing. MRD status mattered. But it looks like our ATG quadrant matters as much or more. Now that's borne out by a slide 1 or 2 down. So let's talk a little bit about age. And again, this is reminding you that our older patients were kind of over here. And what we found is this first line was the optimal dosing in quadrant 1 if you were less than 10 years old. Okay. And this second line is the optimal dosing if you were older than 10 years old. So you remember the first curve where the older patients did much worse. If you were optimally dosed, you did exactly the same. So Chris's hypothesis seems to be true based on the evidence we can present. And here is a non-optimal less than 10-year-old, and we had a number of those, and they did significantly worse. And a non-optimal greater than 10-year-old who really ended up doing the worst in all. Let's talk about MRD. Now, here's a really interesting thing, and that is if you were MRD negative to begin with, we had no patients who relapsed if they got optimal exposure. But if they got non-optimal exposures, they did relapse, and it's reflected, of course, in their disease-free survival. If you were MRD positive, and this is the most important observation that I think all of this adds up to, if you're MRD positive and you had optimal exposure, that 20% that, 25% that Rupert talked about, that's where you fall, even if you're MRD positive. But in this case, if you are MRD positive and you have non-optimal exposure, then your relapse rate is way higher. It's closer to 60%. And so this is a really important observation. Just to say someone who is MRD positive going into a transplant has nearly an 80% chance of survival, that's kind of crazy. But it seems to be in this cohort that turns out to be. And this is a combination of the two where you see this line is optimal MRD. It's MRD negative, but it's optimal. This is MRD positive, but it's optimal. And these two populations are doing the best and matter the most. So again, MRD matters, but ATG seems to matter as much or even more being dosed in the appropriate way. Now, we need to get this data prospectively, and this is because if you look here, this is the number of patients. We had a total of 163 patients in this cohort. And as you see, we only had 2/3 of the patients here who actually had this data measured. We just need more data. So when we measure this prospectively, we will hopefully have more data. But one thing that's really important is those patients who didn't have excessive ATG hanging out. So these were patients who were in quadrants 1 or 2 and their post was less than 12. And what you can see is clearly they have higher CD3, higher CD4 at day 100. Higher CD8 didn't make it. It was a little bit higher, but it didn't reach statistical significance. No difference in NK, and no difference in early CD45 RA recovery. So in summary, younger kids with high ALCs need more ATG in order to push them into the quadrant. Most of our patients need to be dosed further from transplant than day -9 if you're going to give ATG in this model, thymoglobulin. And older kids with low ALCs are going to always be in this quadrant unless you give them way less ATG. And it's difficult to achieve that, but we're going to try. So in summary, precision approaches to a thymoglobulin PK may lead to better survival with less toxicities. What this has led us to is we strongly believe you can use lower intensity regimens, including TBI-free regimens, in patients who are MRD negative, as long as you target them correctly. But with our MRD positive patients, we need to optimize ATG and then give them probably a little bit more of a prep. So we are prospectively validating this approach. And just to give you a description of how we're doing this, we are going to not only optimize ATG, we're going to optimize every single drug. So we're going to have optimal if we use busulfan, we're going to do optimal fludarabine dosing, optimal busulfan dosing, optimal thiotepa dosing, optimal, you name it, whatever drug we're using, we're doing them all based on PK optimization in order to really achieve what we think is the safest and best transplant. We have an intense series of regimens, one for ALL, one for AML, for patients who are MRD positive. We have a reduced toxicity regimen for all the patients who are MRD negative. The vast majority of the patients, of course, will be MRD negative, and none of them will get TBI, whether they have ALL or AML. We then have reduced intensity regimens, truly reduced intensity regimens, for patients who have severe comorbidities or other challenges and can't receive a fully intense transplant. But that's what we're aiming at to look prospectively, and then of course we're going to collect levels of each of these drugs and not only look at how we've optimized them prospectively, but see if that worked and do some validation with that. So this is all the wonderful people who've worked on this particular project, and I'd be happy to take any questions.
So Mike, question and a comment. Going back to the chronic GVH.
Yes.
You sliced and diced it every way, but the one you didn't have was the impact of age.
Yeah.
Because my guess is that the people older than 10 is where a lot of that risk comes from. Because you've started to have some thymic involution already.
Yep.
And my suggestion is, besides the standardization, you should do RTEs on everybody coming in so that you have some direct measurement of the thymopoietic function of them before they get the preparative regime, whatever it is.
Well, that's very interesting and a great suggestion. One thing also that you maybe just think of, and you suggested it may just be that their age is different. So we need to look really carefully with that observation about chronic GVHD, and maybe all the older patients were in the non-ideal quadrants, and there's lower chronic GVHD just because it's a bunch of little kids in the other quadrants.
And the other thing is and I have obviously my biases, is that those people with chronic GVH have reduced numbers of regulatory T cells as the basis of their chronic GVH. And it's going back to this question of what was their baseline thymopoietic function, and what's the impact of the therapy on that, and what's their residual thymopoietic function.
Yeah, makes good sense. Makes good sense. It seems what matters most in all of this is robust immune reconstitution. And if we can figure out ways of achieving it.
But most of that's measured on effector function.
Yeah.
And then it doesn't looking at Tregs. And I think that's the other part, particularly if you're worried about the chronic GVH.
Yeah, makes good sense. Thanks, Robbie.
Robbie, I can't remember what my actual age analysis was on this. I'll have to look it up. But if you remember in quadrant 2, which was the low, those were almost always young kids, and yet their chronic GVH was 30%. So there's clearly something beyond just age.
Yeah.
I was trying to see one that was age when you looked at the swing.
Yeah, I'll need to do that. Thank you for the idea.
So this is Jessie Alexander from Stanford, and I had a similar thought to Robbie, which I consider a really good thing. Although I will say that when I went and looked back to your quadrants, it was really 2 and 3, and 4 was the one with the older patients. So it would be interesting to look at that. I might have missed this in the beginning, but what were the causes of non-relapse mortality? I think, in my head, I'm thinking they're probably mostly infections, but...
Infection and organ failure, and those go together. As usual, when patients go south, they get all sorts of problems, VOD, TMA, blah, blah, blah.
So I think that would be interesting to look at more, too.
Yeah.
And then also, I'm curious, when you did your multivariate analysis and you had your different conditioning groups, did you group some of them together, like TBI, non-TBI, or looking in more detail at the conditioning? Like, how many groups were there when do you remember?
3, TBI, few, or down.
Right.
Okay, so did you see any difference there? In, if you look at ATG versus non-relapse, okay.
Right, and that's surprising because we thought we would. I remember when we were going through this early on, I told Chris early on, I'd never want to treat a patient with busulfan again. Now, I still feel that way. But in general, I had some very bad experiences with busulfan patients, but they were invariably older teenagers who were probably not given the correct dose of ATG.
Thank you.
Yeah.
Great talk, Mike Salim Korachoklu from Regensburg. I don't even know how to spell busulfan, I'm sorry. No, my question is considering the relation of lymphocytes coming into the transplant. So don't you have that in your calculation? I mean, you have a very homogenized population, ALL, AML, with probably a low lymphocyte count post chemo. But let's talk about hemoglobinopathies or non-malignant diseases that have a high lymphocyte count that basically deplete your ATG prior to transplant, so that you should get that part of the calculation as well. Is there any idea on that?
Well, so it's a central part of the calculation in the very interesting and complex equation that was set up by Rick Admiral, and so ALC really does absolutely matter, and that was part of all of it. And the interesting thing is, you would think it wouldn't vary as much, but it varied a lot in our patients. And Chris can say this for sure, we had patients who looked like they'd been treated like crazy, yet they had high ALCs, and we couldn't get them down. And Chris and I have made the same observation. In fact, Chris is going to talk about this, that persistence of lymphocytes is highly associated with relapse, with rejection. This idea that Rupert talked about. So definitely, as we go into non-malignants, if we find a good way to get rid of our T cell, our persistent lymphocytes before day 0, and we'll be much better off.
You probably have to do the same thing for the Neo-V antibody, for the grapholone with a different PK itself. So that's another calculation by itself. Right?
This has been a big challenge. all of the really good PK research has been done on thymoglobulin and not on grapholon. And we need it all to come forward on grapholon so that we can know how to dose grapholon. Grapholon seems to be better in general because it's probably, I mean, the pharmacokinetics are different, but we need the PK on grapholon.
Thank you, Mike. Beautiful work. I just wanted to partially answer a couple of Selim questions, because at the same time, at Stanford, we have run a comparative analysis of ATG doses, exactly with this goal of identifying the sweet spot, and we have looked at that in the malignant and non-malignant. And we had some graft rejection in the non-malignant, so I just wanted to tackle that part. It is clear, so we have used actually an ALC and body weight algorithm in the last portion of the study, but when we looked at all patients together and we simulated the ATG exposure using the same system, the patients who had graft rejection all had a low ATG exposure at day 0. So for treating the non-malignant disorder, obviously this is absolutely crucial. The second point is about the grapholon, which is a super important point because, again, all the data in Europe, I would say most of the data, because there is some experience with hemoglobin, but probably it's less than 20% of the experience with alpha beta haplo, and then we have the grapholon. And when we first started in US, the dose of the thymoglobulin was calculated based on the bioequivalence of the grapholon, which we didn't have so many data about, were data coming from the kidney transplant world. And again, looking at my data, it is clear that if we want to use that bioequivalence, we need to double up what was actually we needed. And so that's where the cumulative dose was initially lower, and then the distal timing that Mike and Chris beautifully showed, how it is important not only for the graft rejection, but also for the immune reconstitution and the leukemia prevention. So definitely more PK data in vivo, but I think that already with this simulated AUC, we have a much better understanding of what we have to do.
Mm-hmm. Yep. Thanks, Alice.
So a question, Dr. Pulsipher. So based on this data, would you make the recommendation even toward non-malignant disorders that is how you would dose the ATG based on this strategy, instead of all the various practice that we see with the ATG for various non-malignant type of transplant for severe plastic, Fanconi's, et cetera, et cetera?
Well, let me give you a simple answer, maybe. And the trouble is that it can be very complicated. It's clear that if this leads toward better immune reconstitution and less chronic graft versus host disease, then that helps anyone. But it all depends on exactly your disease. Now, say, for example, aplastic anemia. One would just say to this, oh, we need to dose it this way for aplastic anemia all the time. Well, the challenge is that the current U.S. protocol done with the BMT-CTN 0301 gives ATG very close to the to the infusion date, and aplastic anemia is slightly different in that you have to keep controlling your autoimmune disease at the same time as you are establishing your immune reconstitution, and HLH is similar. You have to keep controlling that autoimmune disease. And so in addition to that, what we've shown, at least with the aplastic anemia unrelated donors, is you can do, with this particular approach that the CTN developed, you can do a single antigen mismatch and a fully matched donor and have the same outcomes. But you're probably going to need more post-transplant ATG exposure if you're going to do that. So again, yes, this would be a good way to dose it if you're doing alpha-beta approaches. But if you're going to do another approach, you have to figure it all out. Does that make sense? Yes. Right, and YOP, and they have some really nice data that's going to be presented at Tandem in the PEDS plenary session. So if you're going there, you can see that right next to Chris's presentation of this data. Okay, Peter.
Yeah, so this is really an excellent work. May I ask you, do you have additional data about the graft composition?
We do.
So the question is, was there an influence of residual alpha-beta T cells in the graft on the outcome?
You mean as far as dose? So we looked pretty carefully at that, and interestingly, Chris and I, when we started doing this, we were kind of, doses were here, there, and everywhere, but I always was really paranoid, so I would push them up to between 5 and 10 times 10 to the 4th. And then I talked Chris into that, and so he was doing that, and then most of our other centers were just given whatever happened. And so we have a big variation in the alpha-beta dose, and so far we haven't seen a clear relationship with outcome. And Chris, would you agree with that?
I agree. Yeah, I can't find any signal whatsoever.
Yeah, we've tried. We can't find a signal. And I think it's confused by ATG. I think that the ATG dosing is so powerful that it just messes up all of our other questions.
Yeah, it might be that when you have low exposure, then it does make a difference, but we don't have enough patients to say that.
Yeah.
And what was your maximum dose of residual alpha-beta T cells?
Oh, we had almost everyone in this whole cohort was less than 1 times 10 to the 5th. In fact, we probably only had, 3 patients who were higher?
2 or 3 outliers that were up to 27 times 10 to the 4th.
Yeah.
But those are
We were really strict with this from the very beginning. We didn't want to get into high exposures. So, okay, thank you.